I've just given about 7 knowledge areas where you need to have adequate depth in the understanding. And at the same time, it does not mean that you can ignore the other areas. So try to remember and understand as much as possible in the pyramidal tract. So I've just put across certain things which are commonly either discussed or required at the bedside. So first is the origin of the pyramidal tract at the cortex. So understanding of that is important to know the pattern of weakness sometimes, the duration of the weakness, because you will understand that when the lesion affects certain part of the cortex, the weakness recovers quickly, or sometimes the weakness may take a longer period and it may be denser. Next is the arrangement of fibers in the internal capsule and the midbrain. Though it is not of much clinical relevance, it is a frequently assessed knowledge in a postgraduate. Changes in the pyramidal tract at the level of the pons is a very critical knowledge which you should know to interpret certain findings at the bedside. The pattern of crossing over at medulla may also help you to understand the weakness pattern, especially in the upper limb and the lower limb in certain patients with stroke. Arrangement of the fibers in spinal cord important to understand the lesion and the clinical neurological deficit in spinal cord. Connection of the pyramidal tract to the anterior horn cell at a segmental level is something which is very unclear in the literature, so we thought we'll clarify on that part. Then branches of the pyramidal tract, something which we frequently forget, but they play a very important role in the functioning of the pyramidal tract. So pyramidal tract origin, as you would have seen in the Snells Neuroanatomy reference which I had shared, it is contributed equally by 3 groups: the primary motor cortex fibers, the secondary motor cortex fibers, and the parietal lobe fibers. Though by anatomical description they are equal, so the fibers are equal in proportion which contributes the pyramidal tract. In reality, the strength of the fibers falls squarely on the fibers which originate from the primary motor cortex. So why is this relevant? So when the parietal lobe fibers are affected, you may have behavioral dysfunction observed in the patient, commonly for a transient period. And weakness may be very mild and may not be dense at all. Secondary motor cortex may interfere with some of the subcortical processing of the motor fibers. So what you need to understand here is that when the primary motor cortex is affected, the weakness is more denser. Whereas when the secondary motor cortex or the parietal lobe is affected, the weakness need not be denser, despite the fact that 1/3 of the pyramidal tract is affected. So remember, when you start as a postgraduate, when they, for example, when they ask about tell the course of the pyramidal tract, don't just start that it starts from the Betz layer or the cortex. Tell that there are 3 groups which comes together to form the pyramidal tract, and that is the primary motor cortex, secondary motor cortex, and from the parietal lobe. If you want, you can tell the areas, and then you go forward taking the course through the corona radiata and the internal capsule. So when you tell the course of the pyramidal tract, tell like a postgraduate, don't talk like an undergraduate, be more precise. Ensure that a depth is added to your description. So coming to the second one, which is the arrangement of fibers in the internal capsule and the midbrain. So let me just first show you the structures in this picture. So this is the head of the caudate nucleus. This is the thalamus. This is the lentiform nucleus, which is formed by the globus pallidus and putamen. So this forms the relation of the internal capsule. So this is lateral, this is anterior, this is medial. So what you see here is the internal capsule. This is the anterior limb, the bend which is the genu, and the posterior limb. So even in the imaging, in the MRI or in the CT, when you see, you look for the signals of these three structures: signal of the thalamus, signal of the head of the caudate nucleus, signal of the lentiform nucleus, and then you look for a hypointensity, a L-shaped hypointensity in between. Right? So having explained you the structures around the internal capsule, let's go into the internal capsule. Now in the internal capsule, you can see that at the genu, you are seeing the corticobulbar fibers of the seventh nerve. So it is quite anterior. There is a space. So here are the pyramidal tract fibers. The problem with internal capsule is in a small location, all the pyramidal tract fibers come together. They say the width is somewhere as small as close to 1.5 centimeter. So here the fibers are arranged as the upper limb fibers. So the cervical fibers are closer to the genu, whereas the sacral fibers are distant away from the genu. So it is cervical, and then the thoracic, then the lumbar, and then the sacral. That's how it is arranged. So the sacral fibers are distant away. Now this arrangement is not of much clinical relevance, but understand there are a lot of perforators which supply the internal capsule. So it is possible that the branch of one perforator may supply the upper limb, another perforator may supply the lower limb. So this is one reason why sometimes in internal capsulation you can get a monoplegia, especially of the upper limb alone being affected, because that is a perforator being single perforator being occluded. It is quite common in atherosclerotic disease and sometimes even in embolic disease. Right? So I have told you two things. One is the location of the corticobulbar fibers of the facial nerve, then the arrangement of the pyramidal motor fibers from the genu up to the place posteriorly away from the genu. Now I want to give one more answer which actually comes in later part in the sensory system. So here the sensory fibers are also located here, right? So where is it located? Exact location is not that clear, but it is somewhere close to this area. So you have the thalamic radiation, isn't it? All the sensory fibers comes to the thalamus. You would have read about it when you went through the courses of many of the sensory tracts, and they come very close to the pyramidal tract in the internal capsule. We call it as the somatosensory radiation, skin sensation radiation from the thalamus. So this is something which I put the question at the later part, but I thought I'll give the answer at this point itself. So I hope you understood the relations of the internal capsule, the thalamus, the head of the caudate nucleus, and the lentiform nucleus, and arrangement of the facial nerve fibers, arrangement of the motor fibers from the cervical to the sacral, and also the sensory radiation. Now going to the question of midbrain. So this I think you would have seen even in the multiple choice question. One question was this. So pyramidal tract goes through the middle 3/5 of the basis peduncle. You have the peduncle. So middle 3/5. It's not medial, it's not lateral, it is a middle 3/5. So that is something you need to understand here. So rest all is the same. So you just try to understand how it goes. So, and point you need to remember is that this part of the midbrain has very good small perfusion. It has good blood supply there. And maybe due to the presence of the substantia nigra very close to that, it has a very good blood supply there. And therefore, somehow pyramidal tract dense lesion does not affect the midbrain. Some fibers also, they get blood supply from the other blood branches. Perhaps a dense hemiplegia is not that frequent in clinical practice. Now, this is a very favorite question asked in the exam. Of course, the clinical condition we see very uncommon, but it's a fascination in neurology, I would say. So this just shows the cut section of the medulla. So here, this is the upper medulla. So this is the upper medulla, and this is the lower medulla. Lower medulla where the crossing has happened. Now, how does the crossing happen? That is the question here. So you can see that there are two locations. There are two crossing you are able to make out here. Let me just take out the markings. One crossing over is here. You can see that the fiber from the left goes like this. Fiber from the right goes like this. So there is a one crossing here. You see another crossing here. So this fiber comes like this, turns here. This fiber comes and turns. So there are two crossing. So though we technically tell that the pyramidal tract crosses, the upper limb fibers crosses earlier than the lower limb fibers. So this produces a characteristic site, one particular site, where this particular site where upper limb and the lower limb for opposite limb crosses. So let's see what happens here. Let's see what happens on the right side. So this place what happens. So when a lesion occurs at this part, both upper limb will be affected and both upper limb will be weak. But fortunately, the blood supply to this particular point is very good that this site is rarely affected. But whereas the lateral part of the medulla can be affected, we all know that the medulla, the lateral part is very vulnerable. Now here you have a place where the upper limb fibers coming from the left is crossing over the lower limb fibers coming from the right. So this fiber coming on the right side, right lower limb fibers. So this right side actually goes to the left lower limb. So here you have the fiber, upper limb fiber of the coming from the left side, which actually comes to the right side. So it crosses over. So what happens? Upper limb fiber from one side and the lower limb fiber from another side crosses at one point in the medulla before the complete crossover. So this leads to upper limb weakness on one side and the lower limb weakness on the other side. So this is called a crossed hemiplegia, right? So I think if you go back, this picture is actually taken from John Patten Neurology Differential Diagnosis, 2nd edition. So if you can access that book, please read it. This is a very nice diagram of the crossing over which I have seen in neurology books. Very nicely explain how the upper limb fibrous crosses before the lower limb crosses. Any doubt you have in this topic, please put it in the discussion forum, I am willing to clarify it again. So next comes the changes in the pyramidal tract in the pons. So again, let me just quickly revise. So you have the cortex. This is the cortex you have. Then you have the corona radiata. Then it comes to the internal capsule, which is a small location, crosses through the middle 3/5 of the midbrain. Now in the pons, what all we see? This is the 5th cranial nerve nuclei, 6th cranial nerve nuclei, 7th cranial nerve nuclei. You can see that the width of the pyramidal tract fibers is wide here. You are able to see here, it's wide. Whereas here it is very narrow. This is very wide. So why is it occurring? That is because the pons has what is called cruciate fibers. So those cruciate fibers will fragment the pyramidal tract here in the pons. But you can see that once it comes out of the pons, it again becomes smaller. So what happens? A fiber which comes like this breaks like this. So fibers which are close to each other here. For simplicity, I am just drawing 3 fibers. It goes like this. It comes again back down. So this is what happens in the pons. So breaking down of the pyramidal tract fibers, making the thing more broad, and therefore only a big lesion, at least a hemipontine lesion only, can really cause pyramidal tract weakness. When the lesion is small, you would have seen many times in imaging. Pons, hemipontine lesion, when you look at the patient may not have a significant neurological deficit at all. But there will be a transient weakness of complaint and then it will recover. Small pontine lesion. But you know that a moderately sized pontine lesion can be devastating. It can just compress the pyramidal tract on both sides and it can compress the cerebellar structures which are behind it, and it can really be a life-threatening emergency. But when the lesions are small in pons, the pyramidal tract may actually escape, and or rather it won't produce a neurological deficit that densely. I hope you understood this concept. Going to the next question, which is the what happens at the anterior horn cell. See, ultimately the pyramidal tract it goes into the spinal cord, we know that. In the spinal cord, it has to ultimately get attached to the anterior horn cell, isn't it? So let's see, the pyramidal tract comes like this. You have the anterior horn cell. So this is from where the motor route goes out, alpha and gamma motor neuron. This has to connect here, isn't it? So how does it connect? So, and does it connect to the uncrossed anterior corticospinal tract? We know that there is an uncrossed group which is going, which is an anterior column, which is anterior corticospinal tract. You have the lateral corticospinal tract. Does it come to the gray matter? Yes. The answer is yes. So what happens is, we can see that this is the anterior horn cell. So the pyramidal tract gets connects to the anterior horn cell, the same side anterior horn cell, ipsilateral anterior horn cell, through what is called internuncial neurons. So through the internuncial neurons, they get connected to the ipsilateral anterior horn cell. Now at the same time, the anterior corticospinal tract, which is getting descended in the opposite side, because that is uncrossed, it comes in the opposite side, that also gets connected to the same anterior horn cell. So despite the fact that the pyramidal tract has divided in the medulla, come down as separate columns, in separate column, the anterior corticospinal tract in the anterior column and the lateral corticospinal tract in the lateral column, ultimately they join at the anterior horn cell. So let me just draw it separately and show you in detail. And this is again something which is not that clearly described in the literature, but you need to really know that. So here is the lateral corticospinal tract. So let's say here is the anterior corticospinal tract. This is the midline. So this is the opposite half. Here you have the anterior horn cell. At a segmental level, it is going to say the C6 segment or C7 segment. So this crossed pyramidal tract connects to the anterior horn cell. The uncrossed also connects to the anterior horn cell. Then this comes out as the motor neuron. Right? So this is how the connection occurs at the anterior horn cell level, which goes out and supplies the concerned muscle. Hope you understood this. This part is given in Snells, but sometimes somehow the understanding or the clarity of the message is not very clear. And this fact is actually stressed well in the introductory chapters of Adams and also the old editions of Brain. Then we go to the arrangement of the fibers in the spinal cord. Now already I told you how the fibers are arranged in the midbrain and in the corticospinal tract. Now here you can see that sacral fibers are more posterior, then the lumbar fibers, then the thoracic fibers and cervical fibers. The cervical fibers are more inward. So why is this relevant? Is because the compression, especially when there is a vertebral compression, the lower limb fibers are first affected. So they may present with a lower limb weakness first and then the upper limb weakness second. Okay. On the other hand, when it is a central lesion which is expanding laterally, for example, when there is a syrinx which is there central which expands laterally, upper limb fibers may get affected first. We have seen that in syrinx quite often the upper limb there will be what is called a dissociative sensory dysfunction or dissociative anesthesia. When it is more severe, it may compress the motor fibers and it can cause wasting of the upper limb muscle. So this orientation of the pyramidal tract in the spinal cord is relevant for a lesion which originates in the central and goes out, or which comes from outside like a vertebral lesion, or sometimes a extramedullary, extradural, or even sometimes intradural lesion. So the arrangement of the pyramidal tract, the internal capsule, what happens in the pons, and how they are arranged in the spinal cord and how they actually get connected to the anterior horn cell are very relevant in clinical practice. Coming to the branches of pyramidal tract, this I would say an area which is not almost discussed, but it's very relevant. So we all think that when the stimulus originates from the motor cortex which controls the hand, your hand moves. It's not just like that. So pyramidal tract gives branches back to the cerebral cortex. Why is it important? Because it inhibits the adjacent regions of the cortex. For example, when you are actually moving the hand, it's important that as a synergistic, other areas are also excited. The lower limb areas are also excited. So that situation, what they do is that it comes back, the order is only for the upper limb, don't trigger the lower limb, and that inhibits the adjacent region of the cortex. So this inhibition of the adjacent region of the cortex is very important for controlled movement. We know that it makes the movement more smooth, agility, it makes it's more smooth. So that is something which is very important. And it doesn't end there. It also gives branches to the caudate, lentiform nucleus, red nucleus, olivary nucleus, and reticular formation. See, all these have their own descending pathways. These are not, many of them are not named pathways. So it doesn't mean that the motor function is completely controlled by the pyramidal tract. Pyramidal tract plays a significant role for producing skilled movements, which has to be coordinated and smooth, but it is supported by a lot of descending pathways. So they should also receive this signal, isn't it? So when the pyramidal tract is functioning, it inhibits back the cortex, it gives signals to these coordinating structures to support the movement from their side also, right? So this is one of the reason why when pyramidal weakness recovers, all these tracts play a role and they try to bring back your movement, but what is lacking is the skill in the movement is quite often lacking, and the smoothness of the movement is also not. So please go back and read again the branches which is given in the Snells Neuroanatomy and try to understand it again, and I have given you the clinical implication and why that kind of a coordinated connection between the pyramidal tract and the other non-stimulated regions of the cortex and all these structures like caudate nucleus, lentiform nucleus makes sense in a very good smooth movement.